Imagine, for a moment, the most sophisticated building in the world, a massive, high-tech corporate headquarters.
Okay.
This place runs a whole city. It controls everything, the power grid, traffic lights, the internet, all of it. And when it's running smooth, you don't even know it's there. It just works.
It's the ultimate invisible hand.
Exactly. But now, imagine one rogue employee gets inside.
Yeah.
And he just decides to start building a brick wall right in the middle of a vital hallway.
Oh.
Or he goes into the server room and starts snipping wires. Suddenly, the city outside starts to glitch.
That is a terrifying image.
And what?
It's also the perfect analogy for what we're diving into today, because we're not talking about a corporation.
Yeah.
We're talking about the central nervous system, the CNS, and that rogue employee. That's a tumor.
Welcome back to the deep dive. Today, we are tackling a subject that is, I'll admit, heavy, but also just mechanically fascinating. CNS tumors. We're working off a really comprehensive overview by Dr. P.D. Didimson.
Yeah, from Bingham University Teaching Hospital. And Dr. Didimson does not pull any punches. It's a dense text.
It is, which is why we have a specific mission today. This document is thick with terms like, oligodendroglioma.
Right.
So we're going to apply the Feynman technique. We're going to strip away the jargon and explain this in plain English using that corporate headquarters analogy.
I love the Feynman approach. If you can't explain it simply, you just don't understand it well enough.
So let's walk into the lobby of this headquarters. The CNS is mission control, the brain and spinal cord. But it's not just one big blob, is it?
Not at all. It's extremely compartmentalized, like a building with very distinct departments. And this is the first big concept. Location is everything.
In real estate and neurology.
Exactly. Where that rogue employee sets up shop determines exactly what goes wrong.
Okay, so let's look at the floor plan. Who's in the corner office? Who's the CEO?
That would be the frontal lobe. This is the executive suite. It handles, executive functions. We're talking judgment, planning, foresight, and crucially, personality.
The part of you that decides not to tell your boss he has a bad haircut.
Right, impulse control.
Yeah.
And the source material has this really striking example. It mentions a 50-year-old woman. And when you think brain tumor, you think...
Blinding headache.
Right. But she didn't have one.
So what was it?
Her family brought her in because she had personality changes.
Wow. So the CEO isn't screaming in pain. The CEO is just making bizarre decisions.
Precisely. Maybe she's suddenly aggressive or totally apathetic. The tumor is physically taking up space in the office where who I am lives, so the output changes.
That's terrifying. But it makes sense. So if the frontal lobe is the CEO, what about the occipital lobe?
Yeah.
In the back?
Think of the occipital lobe as the CCTV security room. It's all visual processing. A tumor there, you don't get a personality change. You might start seeing flashing lights or lose half your vision.
And the temporal lobe on the sides.
Yep. That's the HR and records department. Memory, hearing, emotional regulation. If the rogue employee builds a wall there, you might struggle to form new memories or have seizures that feel like waves of emotion.
Weird. Okay, and the last big department, the cerebellum.
The cerebellum is different. It's tucked underneath. This is maintenance and logistics. It doesn't decide to move your arm. The CEO does that. But the cerebellum makes sure the movement is smooth.
So if logistics goes down, the CEO says walk, but the legs they don't know the rhythm.
Precisely. You get a stumbling gait, like someone's intoxicated, even if they're stone cold sober. The coordination software is glitching.
This brings me to something I think confuses a lot of students. How can doctors tell where the tumor is without just shoving me into an MRI machine right away?
That's the beauty of neurology. We call it localizing the lesion. You don't need X-ray vision. You just need to observe the glitch.
So you're looking at the traffic jam to figure out which street is blocked.
Perfect metaphor. Let's take a classic example from the source. Broca's area.
A very specific patch of real estate.
Yes, Broadman Area 44, usually on the left side. This is the department for producing speech. Not understanding it, but physically building the sentences.
So if a tumor is sitting on Broca's area...
The patient gets what we call expressive aphasia. They know exactly what they want to say. The idea is clear as day in their mind. But they physically cannot get the words out. It is incredibly frustrating for them.
So if a patient walks in and can't speak, you check the left side. If they walk in dragging a leg...
Check the motor cortex on the opposite side. The symptoms map directly to the anatomy. A tumor isn't just a generic lump. It creates a specific deficit, based on the real estate it's squatting on.
Okay, so that's the headquarters.
Yeah.
But the HQ needs to talk to the rest of the city. It needs cables. That's the spinal cord.
Right. If the brain is the penthouse, the spinal cord is the main elevator shaft running down the center of the building.
Now, I've always thought of it as just one big wire. But Dr. Didemson's notes talk about tracks. It sounds like there are different elevators for different people.
That's a great way to put it. You have ascending elevators going UP to the brain with sensory info, and descending elevators taking orders down.
And even the sensory ones are separate.
Oh, yeah. You have the dorsal columns. Think of these as your luxury elevators. They carry fine touch, vibration, sophisticated data.
Okay, luxury elevators for high-end data. What else?
Then you have the lateral spinothalamic tract.
That's a mouthful.
It is, but just think of it as the emergency service elevator.
Mm-hmm.
It only carries pain and temperature.
Why separate them? Why not just put all feeling in one cable?
From an evolutionary standpoint, think about it. If you touch a hot stove, your brain needs that info right now. It's a survival signal. You don't want that waiting in line behind, the feeling of your sweater.
It gets its own express lane.
Its own dedicated fast-track pathway.
That makes so much sense. There was actually a quiz question in the source about this. It asked which tract is involved if you lose pain and temperature sensation.
And the answer is the lateral spinothalamic. And here's where it gets wild.
Yeah.
You can have a tumor that presses only on that service elevator.
So I could feel the texture of the hot stove, but not the heat.
Exactly. A patient could feel a feather on their arm because the dorsal columns are fine, but not feel a pinprick in the exact same spot.
Oh.
That tells the doctor exactly where the tumor is.
That is incredible detective work. Now, about these elevators, the source uses terms like intradural and extramedullary.
Yeah, let's de-jargon that. Imagine the spinal cord is the cable, and it's wrapped in a protective plastic sheath called the dura.
Okay.
First, you have intradural extramedullary. There's a tumor inside the plastic sheath, but outside the actual wire.
So it's in the elevator shaft, crowding the car, but not inside the car.
Right. These are things like meningiomas. Then you have the nightmare scenario, intramedullary.
Inside the wire.
Inside the cord itself, they're messing with the wiring from the inside out. And finally, extradural.
Outside the sheath.
Outside entirely. And usually, that's metastasis. Cancer that has spread from somewhere else, like the lung, and is now crushing the elevator shaft from the outside.
So we have the HQ and the elevator shaft, but who gets these glitches? Is a brain tumor the same in a 5-year-old as it is in a 50-year-old?
And the answer is a resounding no. There is a distinct pattern here. We call it the rule of thirds.
I love a good rule. Break it down.
Okay, back to the building. The brain has an attic and a basement. The dividing line is a tough membrane called the tentorium.
Attic and basement. Got it.
In adults, it's mostly an attic problem. 2/3 of tumors in adults are supratentorial upstairs, in the thinking parts.
And in kids?
It's completely flipped. 2/3 are infratentorial in the basement, in the cerebellum and brainstem area.
That's a huge distinction. So if a child comes in with symptoms, you're immediately worried about the basement.
Exactly. You're looking for balance issues, vomiting. In adults, you're thinking seizures, personality changes. It's a completely different starting point.
Do we know why? What causes these rogue employees to start building in the first place?
Well, the honest medical answer is usually poorly understood. But we have suspects. Radiation exposure is a big one. And genetic.
The source lists a few, like neurofibromatosis, type 1.
NF1, yeah, and Turcot syndrome. Basically, if your genetic code has a typo in the instructions for how to stop cells from growing, your risk goes up.
Okay, let's get practical. I wake up tomorrow with a pounding headache. My first thought is, oh my God, brain tumor. Address that fear.
This is the most common fear in neurology. But let's look at the data. Headache is the worst symptom in only 50% of patients.
That seems low.
It is. And crucially, it's often a late complaint. Here's the aha moment. The brain itself does not have pain receptors.
Wait, what? The thing that processes pain doesn't feel pain.
Correct. A brain headache only happens when the tumor gets so big it starts stretching the covering of the brain or pulling on blood vessels. By that point, you've usually had other signs for a while.
So if it's just a headache, it's probably stress. When should I actually worry?
The source gives us red flags. 1, new onset headache in a middle-aged or older person. Yeah. If you're 50 and never get headaches, and suddenly you have one every morning, that's a flag. 2, a change in pattern. If you get migraines, your headache. If it suddenly feels completely different, flag. And then there's vomiting. Specifically vomiting without nausea or right in the morning.
Okay, so I come into the ER with these red flags. You need to assess mission control. The source talks about the Glasgow Coma Scale, GCS.
Right.
Let's try it. I'm the patient. Score me.
Okay, I'm ready. GCS is out of 15. It's how online your system is.
All right. I'm 20. Car accident. You walk up. My eyes are closed, but when you come in, I open them to look at you.
Okay. Spontaneous eye-opening. That's full points. 4 points for eyes.
You ask my name. I'm Dave. You ask the year. It's 1995. You ask where we are. The library.
All right, so you're talking, but you are confused.
Yeah.
You aren't oriented to time or place. That means you lose a point on verbal.
Mm-hmm.
That's a 4 out of 5.
Finally, you pinch my arm to test pain. I reach over it with my other hand and grab your wrist to stop you.
That's called localizing pain. It's a purposeful movement. That's a 5 out of 6 for motor.
So the score.
4 plus 4 plus 5. You have a GCS of 13 out of 15. You're online, but the operating system is definitely lagging.
There's another test, the MMSE, the mini mental state exam.
Right. This checks the files in the HR department. There's a mnemonic, oral CL.
Sounds like a dental hygiene brand.
I know. It's orientation, registration, attention, language, and copying. It's just a quick checklist. Can you tell me the date? Can you remember these 3 words? Can you copy this drawing?
And if I fail?
Then we take a picture. CT scan or MRI. And this is where the ring-enhancing lesion comes in.
Sounds distinctive.
It is. On the scan, you see this bright white ring with a dark center.
But the notes say not every ring is a tumor. There's another mnemonic, magic duck R.
Doctors love mnemonics. It helps us remember the suspects. M is for metastasis. A is for abscess, a pocket of pus. G is the big bad one, glioblastoma. Then infection, contusion.
A bruise.
Right. And then demyelinating disease and radiation necrosis. So seeing a ring is scary, but it's not an automatic diagnosis.
But let's say it is a tumor. Let's talk about the villains, the grades. Grade 1 to grade the 4.
Think of grade on as a lazy employee. He's just taking up space, sleeping in the hallway. These are benign, like a meningioma.
Which comes from the covering, not the brain itself.
Exactly. They push the brain, they don't invade it. Usually you can do surgery, pop it out, and you're cured.
But then there's grade 4.
This is the active saboteur, malignant, fast-growing. The classic example is glioblastoma multiforme, or GBM.
The source gets really dark here about the prognosis for GBM. It says median survival is just 12 to 15 months. Why is it so hard to beat?
It's the invasive nature. Oh, so imagine you spill a glass of red wine on a white carpet.
Okay, disaster.
You can blot up the main puddle. That's the bulk of the tumor a surgeon can cut out. But what about the wine that's soaked into the fibers? The stain that spreads out?
You can't get it out without cutting a hole in the carpet.
Exactly. And in the brain, that carpet is your memories, your ability to speak. Glioblastoma sends these microscopic tendrils into healthy brain tissue. You can't cut it all out without destroying the person.
That's a devastating analogy.
It's why it almost always comes back.
So what's the battle plan? How do you fight that?
It's never a solo mission. The source emphasizes a multidisciplinary team. Surgeons, oncologists, radiologists.
All hands on deck.
The standard protocol is usually safe resection first.
Cut out as much of the wine puddle as possible.
Right. Then you blast the carpet with radiation to try and kill the microscopic bits. Then chemotherapy. And the source mentions a targeted therapy drug, bevacizumab.
Big word. What does it do?
Remember how the tumor needs resources to build its wall? It grows new blood vessels to feed itself? Bevacizumab stops that. It stops the tumor from building new blood vessels.
So it cuts the supply lines.
It tries to starve the rogue employee so he runs out of bricks. It's not a cure, but it can buy time.
It really highlights how complex this all is. We've gone from the CEO's office, down the luxury elevators, to microscopic warfare.
It's a lot to take in.
So let's zoom out. What's the big picture? Why does this matter to someone who, hopefully, doesn't have a brain tumor?
I think it matters because it forces us to confront the connection between our biology and our self. If you break your leg, you are still you with a broken leg. But if you have a tumor in the frontal lobe and your personality changes, are you still you?
That's deep. It shows that our personality, our memories, our soul, it's all running on hardware, and that hardware is fragile.
It is. The CNS is the essence of who we are. Understanding it is key to understanding the human experience.
Before we sign off, I want to leave our listeners with one final thought that stood out to me from the source. It says that primary tumors in the spinal cord are actually pretty rare compared to the brain.
That's true. The brain is much more susceptible.
So here's the question to mull over. Why? Why is the wiring the spinal cord so much more resilient than the processing center? Is it because the brain cells are more complex, more active? Or is there something protective about the cord's simplicity?
That is the million-dollar question. It suggests that complexity itself comes with a cost. The more high-tech the headquarters, the more ways there are for a rogue employee to sneak in.
Complexity carries risk, a lesson for biology and for life. Dr. Didemson's overview gave us the map, but the mystery of why it breaks, that remains.
Take care of your mission control, folks.
Absolutely, stay safe.
That's it for this deep dive. Thanks for listening.